Good evening, everybody, and welcome to this evening's lecture from the Turkish Academy of Aesthetic Dentistry. I would like to firstly thank the Turkish Academy for the invitation to come and join you. It really would have been cool to be with you in person, but unfortunately, due to the circumstances, we have to settle for the online. And luckily enough, we have this kind of technology that allows us to actually do this kind of thing. I really want to say thank you for the invitation. It is really an honor and a privilege to be part of one of the most prestigious aesthetic academies in the world, and a very special thank you to Philip Harel for the invitation to be part of this conference. I really appreciate it. What I'm going to share with you is really a philosophy of immediate implant therapy that I've been doing for the last 8 years, and something which has really changed the way that I do dentistry. Something that's allowed me to get the kind of predictability that has always eluded me over the years with all the different techniques that I've had. What I'm going to share with you is I'm going to share with you some of my failures, where I've gone right, where I've gone wrong, and show you the technique and give you a little bit more insight into the technique and how we actually do the technique. Essentially, most of our patients come in, they are looking for a tooth. They don't care what implant you use, they don't care what kind of bone you use. They really care about the fact that they get a tooth, and we all know that on top of the tooth, we all know from Mauro Fradiani, as he said, you can get the best shaped tooth, the best color tooth, but if the soft tissue around the tooth is not perfect, then the case is always going to be either a part failure or never as perfect as it needs to be. So the soft tissue is a key factor for us to be able to get that kind of predictability. And predictability is such an important word, because what it means is that we can get the same results case after case after case. The second most important word is really reproducibility. And reproducibility means that I'm not the only person, or the person that's standing on the podium is not the only person that's able to get the type of results that we're getting here, but that you can take the technique home and you can get exactly the same results, not after 10 times, but after first or second time that you're trying the same technique. And that is very, very important, because I think that's where we lose a lot these days, where a lot of techniques you take home and you fail more times than you succeed. And reproducibility is really one of the keys. So this is the kind of thing that we're looking at, is what we actually think we get. And what we think we get is often this type of scenario where after 8 years, you can actually see that we've actually got even better soft tissue. If we look at what it looks like, we've actually got soft tissue creep. And this is just a case where we placed an implant, no soft tissue graft was done, just a simple delayed therapy. A dual zone therapy where we placed bone, we placed some non-resorbable bone inside the socket between the jump gap. And the critical thing is, how many cases do we actually have like that? Because when we do these kind of cases, this is kind of what we expect. And we expect to get this every single time. The key criteria is, if we have a look at the emergence, if we have a look at the profile, if we have a look at everything that we've got and we see how beautiful the bone is that we've got outside, can we get this type of scenario every single time? Now, the crazy thing is, I'll let you in a secret, that this is my only case that I have. In fact, I have two. I have two cases that look like this, that were treated this way, because the rest of them that I followed up have some kind of collapse or another. So what was right in this case? We had a thick gingival morphotype. We had a large jump gap that we could fill with a lot of non-resorbable bone. We had a thick buccal plate that was greater than 1 millimeter, which meant that we got very, very little resorption of the bundle bone. We used a narrow diameter implant, which gave us enough space between the buccal plate and the implant, and enough space for the jump gap. And we placed the implant in the correct 3D position, which again allowed absolutely perfect positioning. So it was the perfect storm for this case to get ideal. We know, though, that what happens with these cases is that after the extraction, and there's so many different studies, and these are three that we mentioned, Arroyo, Lindy, Chapuis, and Nevins, etc. We all know that there's significant bone loss within 5 to 6 weeks after extraction of the tooth. We know that the thinner the bone plate, the more resorption that you're going to get. We know from van der Weyden that we get a reduction of in the systematic review, that we get a reduction of the alveolar width of about 3.87 millimeters. And we get also some height loss. We get gingival recession in all these cases. So this is what we actually get. In most of these cases, we get a good result. It looks okay, not bad. A little bit of buccopalatal collapse, a little bit of recession. But in low lip lines, it's very acceptable. In very, very high lip lines, and also sometimes low lip lines, but patients who are very aesthetically aware, it's not acceptable. And if we look at this case, you can see there beautiful buccal bone on the outside of the implant, more than 2 millimeters. I think Uli Grunder would be very proud of us to have this kind of case. But you can see still that despite all of that, there is still collapse. So even though we had bone over the implant, there's still collapse of that tissue. And this is generally what we can expect. And these are my cases that I'm showing you here, where we can see that with single implants, we're generally going to get some form of collapse. We're generally going to get some form of gingival recession. And this is just in single implants, because when we start introducing it to multiple implants, our problems get even greater. And often we plan multiple implants just as multiple single implants, when in actual fact, that's not what happens, because the more we have multiple implants, the greater the collapse is going to be. And with single implants, we often get away with things, as I'm going to show you a little bit later, because we have teeth on either side. And the bone on the teeth on either side often will maintain the soft tissue integrity, even if you have no bone. The key factors when we look at full arch cases, and how many cases do we see like this? Because when we go to conferences, these are the kind of cases we see where everybody would be proud to show a 6-year post-op case like this. But in reality, a lot of the cases, and again, these are my cases, these are not other people's cases. These are the cases that I follow up on a day-to-day basis. A lot of my cases look like the one on the right, where 14 years post-op, we've got massive collapse of the tissue. We've got a lot of gingival recession. And luckily enough, we have a situation where the patient has a very low lip line. But if the patient doesn't have a low lip line, this can be an aesthetic disaster. And the other factor with this kind of case is, what is the situation if we now have an implant that's got no bone over the buccal? How susceptible is that implant to peri-implantitis? Have we placed this patient at higher risk of peri-implantitis because of the fact that we did not develop or prevent the collapse of the tissue in these cases? So what are our treatment options for these things? We have dual zone therapy, where we fill the jump gap with a bone substitute of low resorbability. We have the surgical veneer graft, which is where we add connective tissue and do dual zone therapy. So we've got that technique. And the last one we have is contour augmentation, which is the technique punted by the ITI and especially Danny Boozer, where we rather extract, do a delayed approach, place an implant and do a contour augmentation after 8 weeks, which is at the optimal time when the bone turnover stopped taking place. When I look back over my cases, and I look back at the dual zone therapy cases, and this is one that we did over 11 years ago, and we look at this case, and the patient came in, and what was the main issue here? The main issue that the patient came in for was this collapse of the tissue. But in essence, not a terrible result, 11 years post-op. I think most people would be pretty happy with that. But I mean, if we have a closer look at this area over here, you can actually see the darker shadow. And what's that shadow? Is that implant, or is that just light refraction, which is taking place because of the difference in the curvature of the soft tissue? And in actual fact, in this case, you can actually see what happened in this case is this patient had a situation where she started seeing the gray shining through around the top of the implant, and she really didn't like what she was seeing. The great thing about this is I'm a periodontist and I can do soft tissue grafting, so we'll easily be able to just create a contour around that and really just fix this case and make it better. But the crux of the matter is, do I really want cases where I have to go back and continue to do revision surgery over time, or do I want something that's going to give me the stability over time? The second technique that we have in our armamentarium was first proposed by Uli Grunder, where he showed that when you do a connective tissue graft at the same time of placing an immediate implant, we got a situation where we actually gained our soft tissue. And if we look at this case that I'll show you, you can see here, we did an immediate implant, we did a connective tissue graft, We placed a provisional crown on the implant at immediately the same time. And you can see here, when we do the integration assessment, you can actually see how much bone that we've actually gained. And you can see the beautiful contour of bone that we've been achieved in there. And you can see the kind of 3.5 millimeters of tissue thickness that we have there, which is really fantastic. The key fact is, if we look at the case 5 years post-op, you can see that we really have wonderful, stable tissue. And this really, really works well. And I have to say, it's really outstanding. We get similar results. But where I fail with this kind of technique is when I have thin gingival morphotypes, where I'm not able to get as much thickening as I want. And it doesn't allow me to get as good a result as we can. Why did we get a good result here? Because we had good thick buccal plates. We were able to put our implant in the correct 3D position, and we were able to get a good result over time. And with the connective tissue, which prevented or which compensated for the collapse of tissue, we end up with a fantastic result. The problem comes is that some of the cases where we did, like this is a case, we did a surgical veneer graft, we did an implant in the upper right lateral, we placed everything in position. And if we'd have a look at what the case looks like 3 years, I think most people would agree that this is really a successful case. If we look at the periapical x-ray, you'll see that everybody's happy, a nice periapical radiograph. But this is where things fall short, because periapicals are not adequate to show us the success that we have. And it's not adequate to show that we're going to have a long-term successful case. You can also see in this, you can see the internal resorption of the tooth next door. But what I want to show you here is when we take a CBCT, look at what we have. The CBCT shows clearly that there's absolutely no bone over the implant. Now, this was a mistake on my part, because this is a case that really should have got either a contour augmentation or possibly a socket shield. But although that we have a successful aesthetic outcome, and we know from Zucchelli, who says we do not need bone to get aesthetics, we only require soft tissue. And that is very, very true. And it shows you what the teeth on either side are going to give you. But let's look at this case over here, because everything's all in well if you're sitting with a single tooth implant. But what happens if things change over time? And here you can see this case that we did, I think, in around 2008. And what we did with this case, we extracted the central, we did an apicectomy on the lateral. As you can see from the two, there was an apical area. We did an apicectomy, we placed our implant. We did a dual zone therapy. And this is what she looked like in 2008, the way she walked out. In 2010, she came back, and you can see in 2010, you can see that she hadn't changed the temporary yet, and she started to get some recession just 2 years later. So as you can see from this, we've got the collapse. That's pretty much what we expected. And what we did over there, we did a connective tissue graft. We expanded the tissue. We put everything in, and you can see that over time, we pretty much got a nice result. And and you can see there the decent result that we achieved. And you can see now what we've got in that area, which is quite nice over time. The patient came back in 2016 and now had a problem where there was a period where the apicectomy that we did had failed, and they developed a draining sinus over the lateral incisor. When we look at the case and we look at the x-ray and we look at what the bone looks like on the implant adjacent to the tooth, there's a huge warning sign and a danger signal that's saying to us that if I extract that tooth, that bone is going to collapse to the bottom part of where the implant is. So I said to her, not a problem, because we do socket shield, and I'm going to do a socket shield there, and we're going to then be able to place an implant with a socket shield, and that should sort out the situation. But the problem is that if we have a look closely, you can see also, have a look at what the implant has on the buccal. We've got absolutely no bone. Again, a mistake from our side. In the old days when we did dual zone therapy, expecting that the bone that we place is going to maintain the integrity and the bone that we've got there. But alas, it didn't do any of that. So the patient had the tooth extracted because I was overseas. And the kind of disaster that was created because of the extraction that was happened is absolutely incredible, because I really can't fix this now. The last type of possibilities that we have is the contour augmentation, which was first described by Homley Wang all those years ago. And what you see here, this is the classic Homley Wank technique, contour augmentation technique with double membrane, non-resorbable xenograft, etc. And Danny Boozer's group with the Vivian Chapuis published in 2017 this brilliant prospective study where they showed 19 out of 20 cases which had phenomenal bone over the buccal. And they also had very, very good pink aesthetic scores. But the problem with the pink aesthetic score is that it doesn't give you a 3D volumetric analysis, and it also doesn't look at the buccopalatal collapse. And if we have a look at a lot of these cases, you can see here that there's very, very poor soft tissue. And most of them, if you go around, would I be happy with these cases over 10 years? If they were stable, I suppose so. But from an aesthetic point of view, not really great results overall. Okay. The other thing about it is that if we have a look at this case, and this is a case where I did bone grafting on both the laterals, and if you look at them, the question comes down, well, do I actually have bone over the buccal of the tissue? If you have a look at this area, you can actually see that there's massive collapse of the tissue. So the question comes down to who thinks that there's bone over the implants? And normally when I give this lecture, most people put up their hand. You can't put up your hand, but most people will say there's probably no bone there. But let's look at the CBCT. Because if we look at the CBCT, we can see here that we actually have 3.9 millimeters of bone, which is a massive amount of bone. So what does this tell us? And what does Chapuis study, the prospective study of Chapuis tell us? It tells us that sufficient bone does not mean you're going to have perfect soft tissue. And that's really something that's very, very important to see. So why should we consider partial extraction therapy? And the answer really comes in this kind of photo that we see where we've done our immediate implants, and 3 months post-op, you see this most beautiful, exquisite soft tissue profile in this case. But the problem is that 6 years later, you notice that you're starting to get massive collapse around those areas. So everything that looked wonderful after 3 years has collapsed over time. And this really frustrated me because really everything that I was being told about these cases being stable and everybody showing wonderful cases, 7 years, 10 years, the question always entered me, are they showing the exception or are they showing the rule? Because in my hands, I wasn't getting the same kind of results, which really frustrated me. And there was a lack of predictability and there was a lack of biological success over time. So partial extraction therapy really came into being in 2016 when myself and my research partners, Maurice Salama and Jonathan Dutoit, we published these 2 papers. And really, partial extraction therapy really is a group of techniques because people say socket shield partial extraction therapy, they are 2 different things. And it's important to understand the difference. Partial extraction therapies is an umbrella term that embraces 3 techniques: root submergence technique, socket shield and the root membrane, which is 1 technique, and the Pontic shield technique, as well as some others like the Gluckman, the interproximal shield, etc. But these are the 3 main techniques that come under the umbrella term of partial extraction therapies. The whole start of partial extraction therapies really comes down to this publication in 2007 by Maurice Salama and co-workers, where they published for the first time the root submergence technique, which really goes back as far back as about 1965, 1970s. And they brought it into implantology, where they showed that by maintaining a small fragment of the root, they actually maintained the ridge width as well as the papilla unbelievably well, which really gave the patient an incredible aesthetic result. There's 2 types of root submergence. There's vital root submergence, where we have a case where you can see here we sink the nerve just by resecting it. And most people say, well, what happens to the nerve? And there's histological studies that have been done over the years that show that when you do vital root submergence, new dentine bridge forms over the top, and then bone can actually form over the top of that. We close it up with a soft tissue graft, and you can see here how beautifully the ridge is maintained. So it's really the ultimate way to do a ridge preservation technique, because we know that ridge preservation works well, but we don't get perfect results with it. We can also do a non-vital root submergence, where we actually have a root canal treatment that's been done. What we do is we generally seal the root canal with a glass ionomer. And here you can see the follow-up with beautiful soft tissue emergence with a case where we did root submergence and socket shields in all the cases. This is a case that we did many, many years ago in 2006, a motor vehicle accident. She knocked out and avulsed the front teeth and the lateral. And we did some gummy smile treatment. She had some orthodontics. We put in an implant in the upper left lateral. And when she came back 6 years later, she had class 3 mobility of her central. And she also had a deep pocket on the palatal of the upper left central. You can see how beautiful the implant looked in that area. And if we look at the CBCTs, you can see why that implant looked so beautiful, because it had exquisite 2 to 3 millimeters of buccal bone. If we have a look over here, you can see the internal resorption, and over here you can see the external resorption of that case and why we had the class 3 mobility. So in this case, we decided to do an extraction with immediate implant. We decided to do an extirpation with biodentine and a root submergence. And here you can see the case 1 year post-op, 14 months post-op. And you can really see with a high aesthetic value patient, you can see how we've managed to maintain the papilla under the bridge, which is absolutely key. And the root submergence, in my opinion, is what really maintained the case and allowed us to really maintain the soft tissue profile over the years. And had we taken things out, I've no doubt that the central would have collapsed and we would have got a fairly intense collapse of the tissue with possibly loss of papillae in that area. This then takes us on to the next part, which is the socket shield technique, which is really the brilliance of Marcus Hertzler and his co-workers, Otto Zur, etc. And they showed that taking the next step, where you're taking out the bad part of the tooth and leaving the good part, which is the buccal portion, which maintains the ridge and keeps the bundle bone in place, and really foxes the tooth into thinking that the ridge is foxes the bone into thinking that the tooth is still there. And they showed that what happens is that there's zero collapse of the tissue. They also showed in 2 histological sections in 2 different times in 2010 and 2013 that we get excellent bone formation. You can see the bone formation between the implant, both in both of these animal studies that they did. You've got excellent bone formation. The same group, but with Daniel Baumer, the lead researcher, showed 5 years later that what they also had was they had phenomenal preservation of the soft tissue. And they did this not by a pink aesthetic score. They did this rather by doing 3D analysis, by scanning their models and actually doing a subtractive analysis to show that there was actually very little, if any, collapse of the tissue over time. They also showed that the socket shields were very, very solid and stable, and that there was very little change. Then comes the human histology from this. Now comes the human histology from our group, where we showed that with this case where it was an accidental socket shield, you can actually see that in this case, you see beautiful bone formation with osseointegration on the one side and dentointegration or ankylosis on the other side, and the maintenance of everything intact. So it really, really shows with human histology, and there's other human histology from the Greek group, which shows a very similar type of response of the bone. So we now have human histology slides which show us that we clearly have bone formation between the implant and the shield. The next most important part of research was this from our group with myself, Maurice, and Jonathan Dutoy, where we took, this is now the biggest cohort that was done, where we did a up to 4-year analysis, retrospective study, and it showed that we had a 96% survival, which shows really a similar success rate to any other study that shows immediate implant placement. But the one huge factor here that everybody harps on is the 19% complications. Now, the key factor with the 19% complications is that the one factor that is not taken into consideration is that the two most massive complications were internal and external exposures, which made up for 12.4%. Now, the interesting thing about this is that those complications we learned a hell of a lot from, and I'm going to go through them and explain to you why. Because we had no parameters to work from. So through all the years that we were doing the research, we were trying to find out which parameters work well. And this really showed us a lot and taught us where in the new prospective study that we're doing now, we've almost eliminated these complications mostly. And all 12.4% of those complications did not mean that we lost the implant or anything like that. We had no problem with that, and we still managed to either fix the complication and continue, or the implants are still going to this day without any complications. So here you can see in this situation, you can actually see the internal exposures on the two left-hand slides, and you can see on the right-hand side where we don't have any exposure of the socket shield. But still what you can see is that you can see that on all of these three cases, we still have unbelievably beautiful maintenance of the buccal profile. Now, remember that no, no soft tissue grafting has been done in any of these cases. But when we looked at these cases and we started to look at the shields, what we noticed in all the cases where we had good health, we noticed that we had a good amount of space between the shield and the crown, compared to the ones where we looked at where we had the complications, and you could see that the crown was almost touching the shield. And what we realized is that we needed a certain amount of prosthetic space. And this is where we published our publication in the Journal of Prosthetic Dentistry in January 2019, where we showed that by creating a bevel, number one, and number two, by making sure that the shield was at bone level, we made sure that we've almost eliminated these complications almost entirely. So here you can see how we are keeping the shield at bone level. We're creating the chamfer that's creating enough space. Now, initially it was a bevel that was suggested. We suggest a chamfer because it keeps the space continuous all the way from the top to the bottom, unlike a 45-degree chamfer, which then goes closer to the implant. We also place the implant a little bit higher than the chamfer to make sure that we've got good prosthetic space. When we had complications, how we managed these internal shields is we really just trimmed them down. We took a small piece of connective tissue, we sutured it in place, and then we got perfect closure, as one can see from the last slide. And if we look at the same case 1 year follow-up, you can see how beautiful the aesthetic and soft tissue result in this case, with perfect maintenance of the shield. If we have a look at the buccal bone over there, you can actually see how beautiful the shield is in that area and how wonderful the results are without any connective tissue and without any major further bone grafting. Where we had external shield exposure, the treatment of choice was to raise the flap, was to reduce it, to place a connective tissue and close up. And in all of those cases, we got resolution without any hassle. Here's another case that we did. Again, the shield was left too high above the bone, and again, raised the flap, reduce the shield, place connective tissue, and again, ideal, perfect soft tissue healing. So this comes down to now the last publication that we've put together, and this is a decade of socket shield technique, and really puts together what we've learned in the whole proceeding. And what you can see here is you can actually see that in the situation, what we're trying to do is we are trying to create a technique that is easy for everybody to do the same kind of and get the same kind of result as we're getting. Now, there's no doubt that this is not an easy technique, and it's not something that if you haven't done a fair amount of immediate implants, you should just jump in. It's not the technique that you want to jump in if you haven't done any training. You need to certainly do some training, and you definitely need to have the right tools that you're in your armamentarium. But what this publication does is it tries to give you a step-by-step protocol, which I'm going to go through now, and allow you to try and get the same results that we're getting, and to try and make the technique reproducible for everybody. So here you can see the case that we started with. We had a upper right central incisor with internal and external resorption, which you'll see from the thing. It is a thin gingival morphotype, so not an easy case to deal with. And also there was an implant in the lateral already, so it's a central lateral, which really gives us the most difficult case to deal with. It is really one of the most difficult things. The first thing that we do is we work with the CBCT, we retract the lips, and we really look at what we've got. We can see where the soft tissue is. We can measure the distance from soft tissue to bone. We can measure the distance from the soft tissue edge, which is going to allow us to be our marker to get a distance from the crest to the apex. We can plan the shape and the size of our socket shield. We can plan the 3D positioning of our implant, and we can then start with the work. So the first thing that we do with this technique is we cut the crown down to the gum level. You can see here with this case where we have a post in place, we cut around the palatal portion until the post comes out, and then it moves back into exactly the same situation as what we had there. Here you can see where we show you over here, you can see the external and internal resorption of this root. And what we do now is we take a Gates Glidden. We've now measured, we know what the distance is from the gingival margin to the apex. We use a Gates Glidden and we clean out the contents of the canal, going gradually larger to widen that to allow us to get our drill down to the apex. So once we've cleaned out the canal, we've got the space, we now take our fast handpiece. You can see the little marking that we've put on there. We just use the endo markers with a little black felt tip pen. We mark it and we use that again to the buccal. We go down to the apex and we take an x-ray the same way as you would confirm your apical, your apex location with endodontics. Make sure that we at that point before we start to section the tooth. Once we've got to the apex and we're sure of the apex, we can start to go from mesial to distal. And because in this tooth we had an implant on the lateral, we went a little bit further into the interproximal space to make sure that all that interproximal bone was maintained. Once we are sure that we've sectioned the palatal portion, we can now take and start to lever the palatal portion outwards, taking out the palatal portion as atraumatically as possible. And you can see the difference in these things, whereas you can see these ones where I've gone a little bit too palatal. And here you can see I've hit the apex perfectly, and I've hit the apex perfectly on this one. You can actually see what it looks like. So it tells you when you take out the palatal portion, how much of that buccal portion is still left behind and how much work you have to do to eliminate the apical position. The next drill that we use is a 2 millimeter straight diamond. It's a green or a black diamond on a straight handpiece. And the reason we chose this is because most people have this drill, and it is the easiest thing to get very good access to the apex because you can really extend it. And it's one of the most difficult things. And what we do now with this drill is we now start to work at the apical portion, and we go up into the top of the root and we paint downwards. We don't force upwards because then we could perforate the buccal plate. We get in and we slowly work at the apical portion, removing the apex and making sure that we've eliminated any apical tissue, eliminating the lower third of the root and leaving around 2/3 of the root in place. As you can see from this x-ray, we've left as much as we can of that root down the base. We want as long a piece as possible. The longer the piece of root on the buccal, the more stable that piece is going to be. Once we've eliminated the apical portion, we go to the buccal portion, the coronal portion. We take a 3 millimeter drill because we know that we've already measured the distance from the gum to the bone is 3 millimeters, and we make a reduction guide of 3 millimeters in there. And the same as you would do with veneers, we just now continue that portion, but remembering that we've got a contour in. We don't go flat. We make a contour. We create the chamfer using special drills or using a chamfer burr on the inside. We now create that prosthetic space with the chamfer. We use guided surgery to make sure that we get our implant in the correct position, placing the implant just 0.5 millimeters below where the chamfer ends to make sure that we've got the best prosthetic space. We tend to fill up the jump gap with bone if possible. If there's space, we definitely fill the bone with jump gap. And certainly from our prospective study, it shows that we actually get a better bone fill if we do that. Fabrication of the provisional is not really important. We use different techniques, and here we use, this is an old technique. We used to use a putty to index the crown. These days we use the blockout resin to actually index it, which gives us much better assessment and seating. We can see that the crown is seated better. We've got much better visuals. So that's what we use these days. Placing some rubber dam over it to make sure that we don't get anything in there. Etching the tooth or using a porcelain etch if we're using a porcelain tooth. Adding some composite, etc., etc. Putting everything into position, using a toothpick to keep our screw hole open. Curing it, removing it, and now creating our subcritical contour. And this is very, very important that we pay special attention to this detail, because what we do is we create the shape, we put the crown back, and you can see we draw a little pencil line in here. And the pencil line is very, very important, because the pencil line is what's going to tell us where the gingival level is. And now if we have a look at that, we can actually see now that what we want to do, according to the article by Sue and co-workers, we want to now create the subcritical contour where we take away as much of the internal contour as possible, so that we make as much space, as much prosthetic space for the socket shield. Once we've done that, we can then polish up, and we use varying different techniques these days. These days we use special discs, which are much quicker. We use a little bit of PRF just to help to seal it. So this is the poncho technique developed by Alberto Maselli, and putting the crown back in place with very little blanching of the soft tissue. So really, it's just maintaining the contour of the soft tissue and keeping everything in place. And we can see what this looks like. This is at the time, you can actually see what the shield looks like. And I want you to notice, have a look on the left-hand side. You can notice in there, what's interesting is if you have a look at the area over there, look at this area, which is absolutely devoid of bone. And if we have a look at what it looks like 1 year later, you can actually see how fantastic it looks. And look at the bone infill that we've got into that area. But more importantly is look at what the papilla looks like, and look at how the interproximal bone has been maintained. And this is really the most phenomenal part of it, because not only have we not used soft tissue, but we've managed in the most difficult situation, central lateral scenario, we've got no collapse of the buccal tissue. We've got no collapse of the papilla. And I think this is where socket shield really outshines any other technique and really gives us something that is unbelievable. And if we have a look at the maintenance of the contour of both the centrals in this case, 1 year post-op, it really shows us something special is happening with this technique. I've been doing socket shield for 8 years, and this is a special thanks to Marcus Hertzler, because for the first time, I'm able to predictably get the kind of results that I've been looking for, and really absolutely something phenomenal. And this takes us into adjacent implants, which we've already showed you, but again, showing you the most difficult cases, not showing you the easy ones, not showing you two centrals, because those are the ones where we can get some ideal results. The central lateral debate, where we already have an implant in the lateral, we have to place an implant in the central. And you can see what we're dealing with in this scenario, where we have two implants next to each other, a central and lateral. And if we look at the contour, the lateral with no socket shield has some collapse. The implant in the central with the socket shield has zero collapse, and the papilla has been maintained as well as it can. And if we have a look at the periapical x-rays of this case, where we've got external root resorption, and you can see what this looks like. I think this is 3 years post-op. Have a look again at where the bone is sitting interproximally between these two implants. This is something for me that I've never seen. And if you've seen it, then I would love to learn your technique, because it was not anything I could ever achieve in my cases. This is where the bone should be at the best possible scenario, and even worse in the worst case scenario, where it could be sitting even higher up. And it's really something that has shown us absolutely phenomenal results. If we look again at this 5-year result, again, another case, wonderful soft tissue, wonderful papilla maintenance between the central and the lateral. If we look at the two things, you can see the maintenance. If we have a look at this case, look at the maintenance of that tiny piece of bundle bone. And if we have a look at the periapical, this is where it's absolutely phenomenal, because if you look at the case, you can see the green line where the bone is. The bone at best should be at the red line, and at worst should be even higher, because we've got our implants even closer than the 3 millimeters that Uli Grunder suggests that we have. So really something absolutely phenomenal that we're achieving with socket shield. To finish off with, in the last 5 minutes of my lecture, I want to share with you the last part, which is the Pontic shield. And the Pontic shield really is a situation that we use in the Pontic site when we don't have, or we aren't able to do a root submergence. So sometimes with root submergence, we have an apical infection, as you can see from the CBCT behind the picture. And where we have this, we can easily convert the Pontic shield to a socket shield, but instead of putting an implant there, all we do is we curette out the infection, we place synthetic bone, and we close up with soft tissue, and we are able to get exactly the same results as root submergence. Where we have a hyperemic pulp, so if we cut off a tooth and we find that the pulp is absolutely bleeding, it's better to convert it to a Pontic shield, or you can root canal treat the tooth and then submerge it. You could also, if you have a necrotic pulp, it is very, very important either. I would definitely Pontic shield it, not root submerge it. And I wouldn't endo it, because you don't know what's going to happen in 6 months with that endo. So rather take out all the contents of the canal, make sure that you're only dealing with that healthy part of the root. And it's also important here that you have intact buccal bone. Very, very, very important. So just to show you here, this case, you can see where we had an implant. You can see in this case, we had an implant over here with the collapse that's taking place. We did the Pontic shield. You can see the Pontic shield over there, filling the area with bone in that area. And you can see closing. And this is very, very important for both Pontic shield and root submergence, where you make sure that you close up the area either with a free gingival graft or with a rotated palatal flap. And you can see how beautifully we've maintained the soft tissue. And you can also see next door, you can see the collapse here, and even with connective tissue. And you'll see what happens with the connective tissue in this case as well. When you look at this case at 3 years, have a look at what we've got. If we have a look at this case and we look critically at the result, have a look at what we have here. We have pink porcelain. We've got a possible infection around the soft tissue over there. You can see over here, you can see the hyperplastic tissue that took place, where we did a soft tissue augmentation from the tuberosity. But most importantly is have a look at the areas over here. Have a look at the Pontic shield in that area. Have a look at the socket shield in that area. Both of those areas look pristine, look as if they have not been touched. And both of those areas look like they have amazing soft tissue contours. And it's not something that I've been able to get with what we're trying to do. So to finish off with, what I want to share with you is this prospective volumetric data. We are at the 1 year mark, and we'll publish this data early next year. And we have, at this point, 16 cases. We have 100% implant success. We have not lost an implant yet. We have 100% shield success. We haven't lost a shield. We've got no mobility. We've learned a lot from what we've done from the previous publications. And we had one internal shield exposure, and that shield exposure really was because I didn't really pay attention to the contour of the internal contour of the crown. So that really was my own mistake in that area. And but the prospective study is going to show us really at 1 year the results are absolutely staggering and phenomenal. We will be doing volumetric analysis to show the maintenance of everything as well. So what is the future direction? We certainly need much more prospective studies. We need multi-center studies. We need to look at guided socket shield preparation techniques, which will improve the accuracy, improve the reproducibility. A lot of really great people are already doing a lot of cases overseas. Some publications, case reports have already been done on doing guided socket shields, and there'll be more to come. And another one that's a huge feather is dynamic navigation, which allows us to really work without any guides. And that's something which I'm working on now with some groups overseas to develop dynamic navigation as a prospect of doing socket shield preparation through dynamic navigation. So with that, I have to really give a huge thank you to our PET research group from all around the world. And really, it's a privilege and a pleasure to be a part of this group and to represent this group. Really distinguished people, fine people doing amazing work. And I say thank you to them, and thank you for everything that we've shared and developed over the years with that. And with that, I say thank you very, very much for your attention. I look forward to the questions, and I hope you have lots of questions. If you don't want to ask questions online, you're welcome to email me on docg@mweb.co.za. You're welcome to follow us and to send emails to our Facebook, our Instagram page, and join us on our web page. And it's really been a privilege to be with you. And I say thank you very, very much for the opportunity once again to be part of the of the Turkish Academy of Aesthetic Dentistry. Thank you so much for listening, and good night.